my screen is available. I can share the screen or not.
Yeah, it's available.
Is my screen visible to you, Shubham?
Yeah, visible.
Okay. Yeah, but just let me know whenever you want me to start.
Yeah. Okay. So just stop sharing for a second.
Yeah.
Let me introduce and then we'll start. So it's 8:31. Sure. I'll just start the recording. All right. So we'll start. Good evening. It's 8:30 on a Wednesday. It's the Cancer Academy time. And as you can see, my pullover, my jacket is out. So it's getting cold in Delhi. But what is not getting cold is our enthusiasm for academics. And we are still going ahead with the Cancer Academy. Today happens to be a big Indian festival in northern part of India, so we might have some thin attendance, but I'm sure the enthusiasm of our attendees will make up for the absence of some people. And we have a very erudite speaker in Anil. Anil, I have known for, I think now almost 7-8 years, right, Anil?
Yeah.
Where we actually, I was doing surgical oncology and Anil was in radiation oncology, and we now both have moved on to thoracic oncology, where he takes care of thoracic radiation oncology, and I prefer to do more of thoracic surgical oncology. But what has changed and what has remained the same is the question about the role of radical RT in radical treatment of lung cancer, and we continue to debate this, and we thought that this would be a very nice topic to actually have pre-Diwali, have some firecrackers before Diwali, and this is a topic which always ignites passions amongst radiation and surgical oncologists in a live conference when we do it. When we used to have it, now it's been 8 months since we have had anything, but this is a topic still which requires more and more studies, and that is why we decided to keep the lecture as SBRT in early lung cancer. Our narrative to Anil was very clear that we wanted to only talk about early lung cancer, and we wanted to see whether it can be a viable option, and can it probably can we replace surgery or not. God forbid no, but that is what our question to Anil is. Like always, Anil, this talk will be recorded and will be available on YouTube for further references. Our aim is that we have a basic talk which describes the techniques, which describes the indications, some relevant evidence, and then it leaves a message for our audience to look into the existing evidence and take a call on themselves that what is the right option. So with this, I hand over the floor to Anil. Anil is an assistant professor at sorry, I should be calling Dr. Anil. So Dr. Anil is Dr. Anil is assistant professor at Department of Radiotherapy, and he subspecializes in thoracic radiation oncology at Tata Memorial Hospital. A very dear friend and a very nice guy to talk to. So Anil, the floor is yours. You can share your screen. You can switch on your mic, and me and Dr. Geeta will be around for any technical help, and obviously people can put in their questions in the chat box. I'm sure there'll be many, and I'll be asking a lot of these questions if there are. Anil, the floor is yours.
Sure, Shubham. So very good evening to all of you, and thanks Dr. Shubham for giving the introduction, and a very nice introduction. I'm glad that we have Dr. JP Agarwal also in attendance. So he's my teacher and mentor. So it's good to be speaking in front of him. So what I'm going to talk about is SBRT non-small cell lung cancer.
Anil, just give me a minute. Anil, JP Agarwal sir, good evening. I'm making you a co-host, so you have control over your audio and video, and you have the right to interject wherever you feel that we are going astray. Thank you so much for joining, sir. Yeah, Anil, sorry, continue.
Yeah, no problem. So as So as Dr. Shubham has told, that we need to keep this talk a very simple one, but with information about the SBRT and finer details, as well as some evidence to suggest why do you think, or why do we think that SBRT could be a viable alternative option in early stage non-small cell lung cancer. So majority of all the international guidelines to define SBRT as a method of external beam radiotherapy. So it is an external beam radiotherapy that accurately deliver a high dose of irradiation. The word is accuracy and high dose of irradiation in one or few treatment fraction to an extracranial target. So, so this is very important that the word is accuracy, high doses of radiation in one or few treatment fraction. So whenever this is all elements are available in that particular definition, so it is called as SBRT. So what are the indication and how do you select an ideal patient uh, for the SBRT in early stage non-small cell lung cancer? So SBRT indication are early stage non-small cell lung cancer, and we will keep so that as the topic of this presentation. But in small cell lung cancer also, T1, T2, if it is medically inoperable, there are evidence to suggest that we can do SBRT. Post CTRT if there is a residual or recurrent disease, oligometastasis and oligoprogression. But we are going to discuss only early stage. How do you select? The ideal patient selection will be tumor size less than 5 centimeters. The node should be negative, either so radiologically or by, or if you are doing EBUS or mediastinoscopy. The ideal candidate will be in the peripheral location tumor, and the patient should have a pulmonary or adequate pulmonary reserve. But these are not hard in criteria or hard at inclusion exclusion criteria. So what is the rationale for SBRT? We all know that the surgical resection in the form of lobectomy and the mediastinal lymph node dissection is the standard of care, with 5-year overall survival rate ranging from 60 to 70%. But the alternative treatment for this modality was the conventional radiation therapy historically in the era of 1980s to early 2000. However, the tumor control and survival rate with the conventional radiotherapy have been very poor. The local control rate was less than 50%, and 5-year survival is so ranging from 10 to 30%. And SBRT provides excellent local control rate and good overall survival, and there is enough evidence to prove that SBRT has an excellent local control rate, and we will see that in the next future slides. So what is the pros and cons of surgery and SBRT if you want to combine, or if you want to see in comparison? The first of all, the surgery, the pros, it gives you a definitive histopathological diagnosis. So by that, I don't mean only the pathological diagnosis as commerce already know, but in terms of the tumor size or the nodal extension or PNA or LV and all the tumor size. It also enables the invasive nodal staging. For example, EBUS or mediastinoscopy can be done at the same time. And it also allows us to deliver appropriate adjuvant therapy in node positive or larger tumor. For example, adjuvant chemotherapy, which is the standard of care if there is a node 1 positive or N1 positive. Cons are procedure-related morbidity and mortality, especially in the high-risk case of high-risk group, because these are elderly population. And there is an invasive procedure for possibly benign disease, but this indication, but this condition is relatively rare because majority of time we do perform a biopsy, and that is invasive biopsy. And what are the pros for SBRT? SBRT is a non-invasive procedure. 5-year local control rate is more than 90%. It's an outpatient procedure with very mild acute toxicity, and we can actually preserve the lung function and quality of life of the patient. So this is important. The only side effect or the only disadvantage of SBRT is that you do not have a definite pathological variation. You do not have a pathological verification. For example, the tumor site, so the pathological tumor size, which might be different from the clinical tumor size, as well as the nodal status. So what are the criteria of medically inoperable? Because these are the patients that will be referred to the radiation oncologist for doing the SBRT in early stage non-small cell lung cancer. Baseline FEV1 of less than 40%, post-operative FEV1 of less than 30% predicted, severely reduced DLCO less than 40% of predicted, or baseline hypoxemia less than or equal to 70 mm of mercury, or hypercapnia more than 50 mm of mercury. And if exercise oxygen consumption is less than 50% of predictor. So these are the RTOG criteria for defining a medically inoperable patient. So how SBRT is different from the conventional external beam radiation that we deliver in locally advanced non-small cell lung cancer. So you should concentrate only on the 4 topics or the 4 points. The dose per fraction, 1.8 to 3 gray in 3D CRT or IMRT for locally advanced, and SBRT is the 6 to 30 gray. The number of fraction is generally 10 to 13 3D-CRT or IMRT, but in SBRT is only few, 1 to 5 fraction. The target definition, tumor may not have a sharp boundary in 3D or IMRT, but in SBRT, there are, so these are well-defined tumor. The margins that we use or give in 3D-CRT or IMRT is higher, so in centimeters, but in SBRT, it is in millimeters. So what are the features of lung SBRT? So first of all, it's a small tumor size. So as you know, whenever the surgeons cannot palpate a tumor, so which is in the lung, they can't, they wouldn't be able to resect it properly. So the same scenario, if it is the lesion which is barely visible on a CT scan, we may not be able to deliver the SBRT. The tumor motion, the lung moves with the respiration and so does the tumor. So we need to account for that motion to deliver the treatment with a high precision and accuracy. There is a steep dose gradient. What do I mean by steep dose gradient is that it's a very highly dose dependent treatment. If you deliver a X amount of radiation to a point, then at 1 centimeter, you will be receiving like X divided by 10 or something like that. So only 10% of the or the 30% of the tumor of the dose will be received by 1 centimeter. High dose per fraction like 12 gray to 20 gray or 34 gray. We have to use multiple beams whenever you are using IMRT or the conformal arc, and we should be delivering with an accurate verification. So what do I mean by that? I will explain in the next slides. So challenges of lung SBRT. First one is the small tumor size. I have already explained. The lung tissue interface. For the non-radiation oncology audience, what do I mean by lung interface? So lung tissue interface, as you know, there are various types of radiation, and if you do not have a medium, the radiation will travel in the air or in the space. So whenever we mean by lung tissue, that the beam should travel by the tissue and then lung and then get deposited in the small amount of the tissue. So it's a very challenging type of a treatment. So the moving target. So the lung is also moving and the tumor is also moving. So your beam or your arc or beam should match with this moving target. If the tumor is moving, so does the normal lung, which is the organatrix, as well as the tracheobronchial tree, and the moving multi-leaf collimator. Multi-leaf collimators are the beam opening devices for the radiation therapy. So we need to account for the motion trajectory, as we all know that the lung tumor moves with respiration, but this motion is very high, especially in case of lower lobe tumor, as you can see here. So this is the small tumor, but when you do a 4D CT scan or when you want to take a motion into account, so this tumor will move into this particular direction to this extent. So this is double the actual diameter of the tumor. So you need to account for that tumor and you need to deposit the dose in the entire envelope. So what are the key components of motion management? So because motion management is a very important part of SBRT treatment, you can have the imaging based motion management, or you can ask the patient to hold the breath, but which is not very possible, especially in the lung patient because they have a COPD. You can ask for an abdominal compression, but it is not a very it's not a very practical type of a solution. But some institutes do prefer. So we can do more sophisticated like tracking. You track the tumor. Whenever the tumor is moving in this particular direction, your beam will also move in this particular direction. Or you can do the gating. What do I mean by gating is that whenever the tumor will come into this particular position, for example here, only then the beam will turn on. If the tumor is going into this direction, out of this envelope, if it is here, the beam will not be on. So beam will be off. So that is a slightly sophisticated technique, but we can do that. Now coming to the radiotherapy planning. Radiotherapy planning should be done in the treatment position as can be seen here in this picture. So the planning image data set will always be the CT scan because we have the treatment algorithm available and the dose deposition available in the CT data set. So the slice thickness of a planning CT should not be more than 3 mm, and it should cover adequate target and all organs at risk. As you can see, we have covered the CT scan from the apex of the lung till the diaphragm. So the immobilization, because here everything is moving, the lung is moving, the tumor is moving, the organ at risk is moving. So the patient should not move. If the patient is moving, then we can't do the SBRT treatment. So the aim of immobilization is accurate reproducibility. It minimizes the patient movement. It should be comfortable for long treatment because it's a high dose per fraction treatment, and it should be compatible with image guidance of radiation therapy. And they should not interfere with the treatment being. For example, if they have the metal inside the what you call as the the immobilization device. So the beam should not travel through any metal sort of thing. Uh, we have a target volume and margins of a concept. What do I mean by that? We have GTV. So whatever is the radiological visible disease, that will classify as a gross tumor volume. Clinical target volume is for the microscopic margin of the suspected microscopic disease, where you feel that the microscopic disease extension should, microscopic disease extension would be there. So you need to account for that, and you need to account for a CTV based margin. Here in India or in the developing countries, we do see a patient which are of larger tumor size, for example, 4 centimeter, 5 centimeter. So we do prefer to give an adequate margin for the macroscopic disease, but internationally many of the institutes do not give a clinical target volume because of the steep dose gradient. Internal target volume is the tumor motion, as you can see in this picture. So this is the internal target motion or the volume. So it will envelop the entire range of the tumor motion. And then there is a planning target volume because of the setup uncertainty that we are doing on a daily basis. So organs at risk: lung, proximal bronchial tree, esophagus, heart, great vessel, spinal cord, brachial plexus, chest wall, and ribs. These are all organs at risk which can develop an acute or a late toxicity. So you should delineate all the organs at risk. So because a very minor dose also can be deposited in this particular area. So what are the dose per fractionation that we commonly use in SBRT? So this ranges from 10 grain to 5 fraction in RTOG 813 to 34 grain, as we were discussing initially, to 22 to 22 grain 3 fraction. Mind you, there is a difference between external beam radiation therapy dose. If I am talking about external beam radiation therapy, will be 60 grain 30 fraction. So which will not be equivalent to 20 to 22 grain. The biological effective dose that is having an effect on that particular tissue will be different. Here, if I calculate the BED of this particular dose fractionation, it will come out to be approximately 170 approximately. But if we give the same dose in the 60 gray in approximately 30 fraction, so will be approximately 70 to 72 gram. So it is actually less. So SBRT delivers a very high biologically effective dose to the lung tumor. What is the impact of that? So the first doctor who has shown this is Professor Onishi. He has shown that whenever the BED is more than 100 grade, the local control and the regional nodal metastasis are very low. But if it is low than the 100 grade, your local tumor control rate as well as the regional nodal metastasis is very decreased. Means you have a higher local recurrence rate whenever you deliver a BED of less than 100 gray. So it is important to deliver a biologically effective dose of at least 100 gray to the early stage non-small cell lung cancer. Now, we all know that the central sort of a lung tumor are very challenging whenever you want to do the type of surgery also with VATS metastastomy or the early stage non-small cell lung cancer. We also are slightly worried of the central tumor here. So in a very simple language, anything which is close to the mediastinum is classified as the central tumor. Here, so anything which is lower the lower 2 centimeter of the trachea, the carina, the major bronchus, right and left, and so till the division of the segmental bronchus is called the proximal tracheobronchial tree. And when you expand this by 2 centimeter, it is classified as no-fly zone. It was previously. So because they were concerned about the toxicity, as can be seen in this paper by Robert Timmerman, they have delivered 20 to 22 grain 3 fraction, and some of the patients were having the central sort of location. So they have shown that whenever you are treating a centrally located tumor with a very high dose per fractionation, the chances of toxicity are also higher. So you need to adapt and you need to reduce the dose per fraction in centrally located tumor. We will see in the future slides. So what is the ultracentral tumor? Ultracentral tumor is a relatively new term because of the increased indications of the SBRT. Whenever the tumor or your planning target volume is going inside or is abutting or going inside your tracheal structure or any mediastinal structure, it is classified as ultracentral, and the chances of toxicity are still higher than the central tumors. So how do you do the treatment planning of SBRT? SBRT treatment planning can be done with three-dimensional conformal radiation therapy. It can be done with IMRT, intensity modulated radiation therapy, or it can be done with a volumetric rapid arc, so volumetric modulated arc therapy. So anything which is available in your treatment machine can be planned with this technique. Treatment delivery system. Any linear accelerator which has got a 4 to 10 MV of energy can plan an SBRT treatment. If they have the multi-leaf collimator are the beam opening devices with a lift width of 2.5 to 5 mm. Image verification system is desirable, and I will call it as a mandatory. And there are very specialized sort of treatment machine like saber knife and tomotherapy, which can be specifically used for SBRT sort of treatment in lung as well as in the other sites also. So before we deliver every radiotherapy fractionation for SBRT, especially high dose of radiation therapy, we need to match whatever we are intended to deliver is going in that particular area or not. So we take cone beam CT so before every fraction, and we match with the bone as well as the carana as well as the tumor. So tumor is matched with a millimeter accuracy. If the tumor is not matching, we need to repeat the entire setup right from the immobilization. Okay. So now coming to the evidence of lung SBRT, we will not go into the very details of about the lung SBRT. We will present the data of the lung SBRT. I'm not going to debate SBRT versus surgery, but will present the data of SBRT. So these are one of the few articles that were published from Japan by Nagata et al. They have shown that the 3-year loco-regional failure survival for stage 1A and 1B is close to 95 to 100%, which is excellent. 3-year overall survival for stage 1 and 1B is 83 to 72% respectively. So SBRT can give an excellent loco-regional control rate. So this is a paper from the US, so by the same author, the Robert Timmerman. They have also treated like SBRT with a 20 to 22 gray per fraction with a 3-year local control rate of 88%, but their 3-year overall survival is 43% because they do have a majority of the T2s and the sort of a tumor which is more than 3 centimeter. As you increase the tumor size, the overall survival rate of SBRT goes down because this patient have higher. So these patients are elderly and they come with a multiple comorbidities, and so believe me, so these are medically inoperable. So that's why they have multiple comorbidities, and that's why they were not eligible for lobectomy. But the cancer specific survival is close to 80%. So this is the same paper. So this is the same group which have shown that RTOG 0236. So this was the first prospective phase 2 study which has shown that the 5-year oral survival can touch a rate of 40%. There are various retrospective studies which have shown that the local control rate at 3 years or 5 years is more than 80 to 90%. So the local control rate is excellent. So the same thing with the prospective studies also, the 3-year local control rate is more than 85 to 90%, and the 3-year overall survival ranges between 40 to 60%. So these are medically inoperable patients. We will see if we deliver the treatment, SBRT treatment in operable patient, what will happen. So, yeah, is there any randomized controlled trial if we want to compare, because the retrospective and prospective are not the level of recommendation that you will suggest in an evidence-based medicine. So there were multiple attempts of doing a randomized controlled trial of comparing SBRT versus surgery, but all were prematurely closed. And these are the example STARS trial and the Rosal trial. And their pooled analysis was published in Lancet by Chang et al. Only 58 patients were randomized, T less than 4 centimeter, and they were operable. So 31 to SABR and 27 to surgery. You will be surprised that the 3-year overall survival rate was actually better in the SBRT arm, 95% versus 71%, but these are not properly conducted and full randomized control trials. This is a very subset type of analysis of only 58 patients. But you can, so the authors here concluded that SABR could be an option for treating operable stage 1 non-small cell lung cancer because of the small patient sample size and short follow-up. Additional randomized studies comparing SABR with surgery in operable patients are warranted. So this is the paper. So this is the retrospective comparison by Greels et al. Between SBRT and wedge resection. So all patients were ineligible for lobectomy. SBRT patients were medically inoperable, so they did not undergo the wedge recession, and they were treated with SBRT. If you see, they have compared 124 patients. The local recurrence, the regional recurrence, as well as the local regional recurrence were less in the SBRT arm as compared to surgery. But overall survival was less in the SBRT arm as compared to the surgery arm because of the obvious differences. So these patients were medically inoperable even for the wedge resection. But the cancer specific survival, especially lung cancer specific survival, were exactly matching in both the arms. So this is a retrospective comparison. RTOG 0915, do you really need 1 to 3 fraction or 1 to 5 fraction? Can we do it in one fraction like an SRS of the brain? So this was the study. So this was a phase 2 randomized study, and the primary endpoint was the toxicity at the rate of 1 year. So they randomized between 34 gray in one fraction. So the patient has to come in the morning, and he or she can go back in the afternoon by after doing the treatment. So as compared to 4 fraction. So the long-term results, they have documented that there will no additional toxicity were reported in 34 gray in single fraction versus 48 gray in 4 fraction. But the patient selection criteria is very important. So the tumor size should be less than 3 centimeter, and it should be in the peripheral location, 2 centimeter away from the chest wall, and not in the central or ultra-central location. So these are very highly selected group of population for 48 gray, for 34 gray in one fraction. The overall survival rate were actually comparable 5-year overall survival rate of 30% versus 40% in 48 gray in 4 fraction, so which were not statistically significant. So what will happen if we deliver SBRT, if we deliver a conventional radiation therapy to a dose of 60 gray in 30 fraction to early stage non-small cell lung cancer? So the local control rate and overall survival is actually very poor when you compare with the SBRT. But this was the data from the older studies like 1980s to 2000. So are there any randomized control trial to prove that external beam radiation therapy in a conventional manner is actually inferior? There are 2 randomized control trials to prove that, not to prove that basically. So they have randomized 102 patients between SBRT and conventional, and they have shown that when you see the progression-free survival, they are not different. 3-year progression-free survival was 42% in both the arms, and 3-year overall survival was actually better, so was actually same in both the arms. But the incidence of pneumonitis and the esophagitis were actually less in SBRT arm as compared to the conventional EBRT arm. And mind you, so this were the treatment duration. So treatment duration in SBRT will be maximum 1 or 2 weeks or 1.5 weeks versus 7 weeks of conventional EBRT. So the patient would prefer, if both are equivalent, to come for a lesser treatment duration than the larger treatment duration. So this is another randomized control trial between conventional and SBRT. They have actually shown that overall survival at 2 years was actually better in the SBRT arm as compared to the conventional EBRT arm. Local control rate was actually better in SBRT versus the conventional EBRT arm. So we have divided consensus or divided evidence between conventional EBRT or SBRT. So the current management or standard of care is SBRT for early stage non-small cell lung cancer for radiotherapy. So what will happen if we deliver for operable patients? So this is a Japanese clinical oncology group paper. They have shown that whenever you treat a patient of operable patients with SBRT, so in inoperable patient, the 3-year overall survival was only 60%, and the 3-year overall survival was 75% in operable patient. So whenever we do treatment for operable patient, the survival is also better because they do not have a medically inoperable or comorbidities. So this is another paper. It has also shown that 5-year overall survival was better in operable patient as compared to inoperable patient. So, but for obvious reasons. How do you want to do the treatment? Do you want to do it daily? So to treat 4 fraction on a daily basis so that you can complete the treatment in 4 days, or you want to do it on alternate day basis? Whenever you want to do it on alternate basis, the advantage is that the normal tissue will get some time to repair. And this was shown in this paper by Jain et al. That whenever you do the treatment in 4 days, your grade 2 or higher acute toxicity was more as compared to when you give a gap of at least 24 to 48 hours. So the normal tissue will get some time to repair and the acute toxicity will be lesser. So you need to have an adequate gap between 2 fractions because these are very high dose, like 12 or 18 or 22 gray per fraction. So what are the ongoing trials of SBRT versus surgery? So these are the 4 randomized control trials that are ongoing, but the result will be available by, I think, 2025 or 2027. To my knowledge, so the Saber-2 is not doing very good as far as the accrual is concerned, but the stable mates is comparing sublobar recession versus SBRT, and its accrual is actually doing good. What happens to elderly patients? So this is an important and very interesting slide. So this is the Amsterdam Cancer Registry from Netherlands, and they have shown the 3 era, for example, 1999 to 2001, so 2002 to 2004, and 2005 to 2007. If you see at the top, there were 38% of the patients who have neither been offered SBRT or who are not eligible for the surgical or SBRT, and only 26% were opted for SBRT because of medical inoperable. But if you see in 2005 to 2007, the proportion of patients undergoing RT increased significantly from 26% to 42%. What we want is that this 26% will be zero. So either the patient opt for surgery or SBRT, but no patient should go without treatment, especially of early stage non-small cell lung cancer, because these are curable population. Is there a lower limit of pre-treatment pulmonary function test parameters as that of the surgery? I would say no. So as can be seen in this paper, that the pulmonary function tests, they were significantly correlated with the overall survival, but not cancer-specific survival, because these are COPD patients with a poor pulmonary reserve. So poor pulmonary reserve will affect the overall survival, but not the cancer-specific survival. They can die or expire because of the intercurrent death or the respiratory-related mortality. So this paper has shown that whenever you see a DLC of 11.2, when you have the cutoff 11.2, the overall survival is better as compared to the DLC of less than 11.2. But the radiation-induced pneumonitis or the toxicity is not actually so different between the two groups. SBRT in COPD patient, as is expected, whenever you treat a patient of severe COPD versus very severe COPD with SBRT, severe COPD patient has got a better overall survival as compared to very severe. So obviously for the intercurrent death or the respiratory related mortality, but not the lung cancer specific mortality. So what are the toxicities of your SBRT treatment? Because so pneumonitis is the most dreaded complication of any thoracic RT, and it is the most common side effect of thoracic RT. But in SBRT, majority of radiation pneumonitis is of low grade, approximately 10 to 20%. And low grade means the patient do not have any symptoms, only radiological changes are there. So grade 3 or higher than grade 3 pneumonitis is actually less than 5%. And if you have a proper infrastructure available with good experience, so this grade 3 pneumonitis can touch 0 to 1% also. So the risk factors are the centrally located tumor, larger tumor volume, and the interstitial lung disease. Obviously, the COPD is included in that, and the dosimetric parameter and the dosimetric parameter. You need to keep your organ at risk doses, that's the normal lung doses, as low as possible. So if you have a mean lung dose of less than 6 gray and V20 of less than 20, V20 of less than 10 gray, the pneumonitis rate were actually very less. Now coming to the chest wall toxicity, because so chest wall toxicity is also important. So in the peripheral tumor location, the incidence is approximately 10 to 20% whenever your GTV or the PTV is going into the chest wall or is abutting the chest wall. So estimated risk of chest wall pain at 2 years was 20%. But the median onset of chest wall pain is approximately 6 to 12 months, and it will be like a dull aching pain or a mild pain, which can be relieved with paracetamol, and it's sort of a temporary. And the median onset for asymptomatic rib fracture is 12 to 18 months. And the factors that are predicting is the close to the chest wall tumor location, close to the chest wall location, active or past smoker, BMI, so diabetes, and the V30 dose. The V30 means volume receiving the 30 gray of isodose. So with this, I would like to conclude my talk. So this is an example of the chest wall toxicity. As you can see, the chest or the skin is puckered or that particular area where there was a tumor. So you can have this chest wall toxicity if you don't see your chest wall doses properly. So with this, I would like to conclude my talk. If there are any questions, I would be happy to take it.
Great. So don't close your presentation as of yet. Just go back to the as a disclaimer, I'm a surgeon. So
Yeah,
for
yeah.
those who don't know, no, because I am the one who's most interested in a talk like this. So there was this paper where we compared wedge resection to SBRT, the
Yeah. Great.
non-anatomical wedge resection. Yes. So yes. So my biggest thing is that the surgery is obviously something which is not appropriate in this arm. Local recurrences as high as 20%, and we all agree that surgery is never going to be a wedge resection. A non-anatomical resection is not something that we aim at, and we would any day tell that patient that probably you are medically inoperable and go for a non-surgical modality. But how would we explain the OS being better for surgery as compared to SBRT when we are using actually an inferior modality for surgery? So I have not seen this paper. Actually, I would be very interesting to see the cause of death in this, although the cancer specific survival is good. So is this related to the morbidity of SBRT, that in spite of recurrences being high, the cause of deaths were higher in SBRT arm?
No, I would not say that. But for the first point, so I will agree with you. So this was the paper, or this was the retrospective comparison done in the era of, I think, 1995 to 2004. So obviously the surgical techniques have evolved, the radiotherapy techniques have evolved, but the overall survival rate were not low because of the SBRT related morbidity. As you can see, the SBRT patients were older with higher comorbidities. So we all know that the patient are not going to live that long enough to have the lung cancer specific mortality. So these patients were elderly, and so most probably with higher comorbidities. So that might have caused the dip in the survival rate of SBRT.
Yeah, that is one possibility. Okay, and what is your take on post SBRT follow up? When once we give SBRT, we ask those patients to follow up. So, how would you assess those patients by getting a CT scan or a PET CT scan, because that lesion many times persists as a burnt out lesion? So, how would you follow up these patients?
Yeah, so for the follow-up of the patient who have undergone SBRT treatment, what we practice in TMH is that for first follow-up, we only ask for a PET CT scan. After that, we will follow that patient with a CCT scan every 3 months for the first 1.5 to 2 years, and then every 6 months so with a chest X-ray and the CT scan, so once in a year. So as rightly said by Shubham, if you keep performing the PET CT scan, it will always show some uptake. So because of the higher dose induced inflammation in that particular part of the area where we have treated. So whenever you do a PET CT scan, it should be viewed very cautiously that anything which is increase in SUV will not be related to the recurrence. You will actually have to see and sit with the radiologist and discuss with them, because post RT fibrosis can be so misinterpreted as the recurrence. So there are papers which have suggested or which have demonstrated that you can have the PET CT based inflammation or increase in SUV till the level of 2 years. So whenever you are seeing a slightly bulging opacity, which can increase in the size, very smooth margin, and not like a radiation related changes, so you need to biopsy that. Otherwise, there is no need for biopsy. So for follow up, the CT scan is an adequate and ideal modality.
Okay. So can we have Dr. JP Agarwal's view on this, sir? Sir, if you are willing to come online, sir. I know that you're there, sir.
On what, dear?
Sir. Yes, thank you for joining.
Good evening.
in,
Good evening.
Sir, adjuvant treatment for persistent PET uptake in post SBRT patients, sir, because that is our morbid fear for a surgeon, that if you offer radiation to that area and that continues to shine up, we might not be, because that patient was initially obviously not operable, and now what we will do?
So, Shubham, there is, I think, one of the reasons, if you really see that in patients where you have not been able to give adjuvant completely, the outcomes were nearly dipped and nearly same as the patient of SBRT who has not received the adjuvant. So indirectly, there is a need for adjuvant, but to give an adjuvant, we don't have the optimal patient conditions like a good KPS, good performance score, their ability to withstand the treatment. Hence, we are not able to give right from the day zero, even if they are more than 4 centimeters.
Hmm.
Now, the question of continuous signing up, I think PET is not to be done. I think Anil said it again and again. Uh, it is not a good thought. So there is a nice paper by David Palma. So they did patients of SBR, the patients were potentially for resection, and they did a SBRT on that. So what they saw after 6 weeks, 4 weeks, I think, if I remember correctly, 40+% of the patients still had residual disease. So that is probably not also the optimum time of doing a scan at even 10 weeks or 12 weeks in patients whom you were giving SBRT. That is one. And secondly, I think some point of time, if we want to do SBRT in operable lung cancers, I think we should be offering them adjuvant treatment, depending upon 4 centimeter size or some parameters. So the trials are there, a few early trials are there, especially for the driver mutation ones. Okay, so I
Yes.
think at some point of time it will come up in the literature.
We also have one with durvalumab, sir, where they're trying to actually extrapolate the
I,
CTRT. Yes, they are trying to do that.
I think I wrote to you on
Yes,
your.
I wanted to highlight that only, sir. That thing they are trying to do it, and they're trying to enroll
Yeah.
more patients. Yes.
So they will come up sometime in future, but I think at this point of time, uh, they are expensive stuff, and they should be reserved in the trial only. In even the adjuvant should be in the trial settings only, not in the routine common setting.
Sir, if I were to counsel a patient right now, uh, if you offer a patient a non-surgical modality, they will jump at it. Would I be correct in telling that you can go for SBRT if you want to? I'm asking you because you are the most affected party. If I tell them that you should
Okay.
go for surgery, they will radiation is not the correct treatment. So that is how I feel the counseling is very important. It has to be
I
correct for the both
completely
sides.
agree.
Yes,
So
yes,
first fundamental is multidisciplinary approach.
sir.
Okay. The second is if the patient is quite young,
Hmm.
let's say 45, 46, okay, and he was never a smoker or something like that. So I think I will ask Shubham, you please go ahead and take it out. That's my, okay,
Okay.
because that will be though bit morbid, but he will definitely withstand that and it will be helpful. And whenever it is a lobectomy, I think the likelihood of mortality is going to be less than a percentage. And the
Agreed, sir.
ICU stay is hardly going to be there within a day or two. The patient can go home, do vigorous exercise. Within 7 days, I think he's up and about. And he will be a candidate of an adjuvant at some point of time. So we are measuring 1 centimeter, 1 centimeter. So that's the way. So we can take a call that what percentage of acceptance of recurrence or mortality we want, and he will be able to complete his chemo completely smoothly. So I will definitely ask that patient, Subham, please take it out. If he's
Agreed.
an elderly gentleman, and if they are borderline situation, I think I will go tend towards non-surgical with inbuilt trial system to be there that whether he is able to take a adjuvant treatment or not. I think I will go on that count.
Sir, many times, we have patients who are morbidly scared of surgery. And if the same patients, although young, continues to tell you, sir, that if I can avoid surgery, I will be more than happy. Would you then offer that patient radiation, or would you continue to tell him that no, you should still go for surgery because that is the gold standard?
Okay. See, we don't have a direct evidence, right?
Yes.
So it is our duty to explain to the patient by audio visual or with the patient experiences, what is going to be the correct way? See, everybody is afraid to undergo a knife,
Yes,
anesthesia,
yes.
ICU. They're frightening, right?
Mm-hmm.
Absolutely frightening. And definitely, I'm not saying as a radiation oncologist, as an oncologist, that we need to take the patient in confidence, the family in confidence, the supportive care they will need it after the surgery, immediately after the surgery, and all those things. No, selling is easy,
Yes.
but we as an oncologist, and you said it. I think the most important thing what I like, Subham, behind you and above you is the Cancer Academy, and that's what we were talking with Geeta right now. That, see, we need to educate people, and that's the
Agreed.
noblest one. Okay, selling is not the correct way,
Yes, yes.
and we need to educate the people and let the people take the decision. And if or she or he is convinced though that he is morbidly scared, please avoid the patient during surgery. He is not going to cough out during the ICU, right? He will not do chest breathing exercises. I don't want a static pneumonia post surgery. Yeah, it will create more mess doing a bronchoscopic aspiration and all those stupid things, okay, which we'll never want to do it unless until we are forced to do it. So a patient who is not going to be cooperative, scared, and all those things has a hyper pain phenomena, we should be just taking a back seat, really think over before selling those things also.
Agreed, sir. So, sir, do you suggest that both the radiation and the surgical oncologist should talk together to the patient? Because what happens, I counsel the patient, I send him to the radiation oncologist rooms. I don't know what they have spoken. He comes back, or he goes there first. He comes back. So I don't know. Is there a trust issue, or should we be counseling them together?
Better together to begin with. And
Yes.
once you know that, I know, Subham, what you will talk, you know what Anil is
Anil will
going to
talk.
talk. So
Yes.
then it becomes a non-issue.
Non-issue. Agreed, sir. Agreed. I think that is what we need to do. Actually, sit together and tell the patient,
In
and
the
we have to be.
beginning, I think, yes.
Yes. Yes.
And most important that we need to educate our pulmonologist also.
Mhm. Okay.
Okay, because ultimately they are going to take care of those things. We will be there for very few number of days with them. So ultimately in the field, pulmonologists, so that will help us for sending the new patients as well as taking care
Of the
of
old ones.
affected lung or radiated lung.
Yes, sir. I agree. Thank you, sir. Thank you so much. Thank you.
Thanks, Anil. It was a
Yes, sir.
great
Thank
job.
you, sir.
I wanted some Indian data only. Next time, I hope.
Sure.
So, Anil, there's a question in the chat box that what if there are, this is by Dr. Shanu Jain, that what if there are multiple multifocal small lung lesions? You know, you have more than one lesion, probably same lobe versus different lobe. What would your approach be then?
So it's very important to distinguish between like a second primary lung cancer versus a metastasis. So that is the very first thing that will come into your mind whenever you see one nodule of 1 centimeter at one point and one nodule of 1 centimeter at some other distant location like 2 centimeter or 5 centimeter from that. So we need to differentiate whether it is a metastasis or a primary. So so because if we want to do, for example, SBRT for two different locations, it is possible. It is technically very easy and not very challenging sort of a job. But if you do it for a metastasis, the outcome will not be the same as that of two separate or the two second primary lung cancer. So we need to explain to the patient that it might be a metastasis, it might be, I don't think so. As far as the pathology is concerned, I'm not an expert in pathology, but they won't be able to differentiate only on the histopathological data. They will need some genomic sequencing or I don't know what to differentiate from the primary and the metastasis. So whenever you have the metastasis or a second nodule, you need to see how far is that from the first lesion, whether you would be able to do it safely, and if you are able to do it safely, explain to the patient and then you can proceed.
Also, I think that if there are, even if they are not metastatic or then you already upstage it. So SBRT is basically for T1 lesion
T1, T2.
and bordering T2, 5
Mhm.
centimeter is what you said, but I think 3 centimeter is a good size. But this will, if you have two nodules in the same lobe, it will
It's a
anyway
T3.
become T3. And if
Yes.
you have in different lobes, even if they are non-metastatic, you consider, they will become T4. And then the nodal evaluation becomes very important because
Yes.
SBRT should only be offered to patients when you are very sure that they are not going to be any nodal disease, because you are not addressing the nodal base
Node.
as such. So, which actually brings to this question that although you said that the size of lesion that you are ready to accept is up to 5 centimeter, if the lesion size is more than 3 centimeter, would you consider getting a mediastinal nodal evaluation? Because the existing guidelines that we have is that you can avoid a mediastinal evaluation for a peripheral 3 centimeter lesion.
Yeah.
But if
So
you
according
have,
to the
yeah,
So, as rightly said, according to the ESTS guideline also, which was published in 2013 or 14, I think, they have said that you can avoid a mediastinal staging,
staging,
especially in a less than 3 centimeter or 2
yes,
centimeter peripherally located
peripherally.
tumor. As we know that if the tumor is more than 3 centimeter, obviously the chances of nodal metastasis are higher.
Mhm.
And if the tumor is located in a centrally located tumor near the hilum, so obviously the chances of N1 is also higher. So
Okay.
I would be very happy if the patient and my pulmonologist or thoracic surgeon are able to do the e-bus. We would be happy. In TMS, as far as till today's date, we have a long waiting list for the e-bus for the radical patients.
Mhm.
And when so there are various data available from the surgical series also, and from the non-surgical series also. So those shows that if your PET-CT scan is not showing any nodal uptake and the node is less than 1 centimeter, so the chances of coming out to be N1 or N2, for example, skip N2, will be less than 10% if your size is less than 3 centimeter. But if the size is more than 3 to 4 or 5 centimeters, so the chances increases. So you need to be very careful and watchful and discuss with your medical medicine and the radiologist that if you have any suspicious node, whether it is looking malignant or benign based on the radiological criteria, also on the PET-CT uptake wise. So because so India is an endemic country for the TB, there will be many false positive radiological node, as we know from the e-bus data. So there are many multiple station N2, but when you do the e-bus, they will come out to be so they will become non-malignant. So we have both ways. They can come positive also, or they can come negative also. So for that, it will be easier for the surgeons if there is a less than 3 centimeter nodule, and so one node in N2 category, for example, N2, but it is less than a centimeter, and you do the e-bus and it come out to be negative. So you don't have to do so for example the mediastinal nodal staging if you are done only the
Yes,
single
yes,
nodal
yes.
e-bus.
Okay, okay. And what is your take on, although this is not a part of the topic, but in case of oligometastatic cancers where the lesion is in the lung, would you consider SBRT for isolated lung metastasis?
Means you so the
So the
primary is different.
primary is elsewhere. There's an isolated lung met. So suppose it's a bone primary with an isolated lung met. Would you consider SBRT for that? Would you suggest?
Yes. So, if the primary is going to be controlled and if the surgery is not possible, as we know from the solstice from the meta-analysis that is comparing the metastectomy. So depending upon the primary, if the surgery is not possible, we can consider for SBRT for that same lung metastasis. And at TMH, we are doing so SBRT for the oligometastasis as well as the metastasis that comes in an oligo recurrence setting or oligoprogression. We are doing especially a lot, not a lot, but very frequently, especially in the era of the targeted therapy and the immunotherapy, because they get controlled at the primary and the extrathoracic, and one nodule popped up, or,
Mhm.
or one nodule pops out. So we are doing SBRT for those patients.
So, would your choice of such patients depend on the type of primary, whether it's going to respond to radiation or not? Because if it's a osteosarcoma where you know it's going to be a calcified nodule, would you still offer them SBRT?
No. So my treatment, so my indication for SBRT will also depend on the histology. As
Histology,
you
yes.
rightly said, osteosarcoma, if you can reset it out, so it would be the first choice, especially for osteosarcoma, because these are calcified
Yes,
lesion.
yes.
The osteosarcoma will require a very higher doses to control, and also from the colorectal primary. Colorectal primary, as compared to the other primaries, they require a slightly higher doses. So if in case the surgery or the wax metastectomy is not possible, or the patient is not willing to undergo the surgery, we would offer that. But my indication will also differ according to the primary histology.
Okay. So I don't have any. I'm not sure if I have any surgeons in the group, but what is your feedback that you have got from your surgeons, that have they ever had to operate on a post SBRT lung? You know, I'm sure it's not a because he was obviously inoperable that he got that thing, but
No, no. So
SBRT.
the unfortunately, unfortunately, SBRT patients who are medically inoperable will not survive so much
No,
long
no.
to
Yeah,
develop a recurrence at that particular
develop a
site.
recurrence, but sometimes what happens is that the patient chose SBRT because he did not
Oh,
want to undergo
yeah,
surgery,
yeah,
and
for
then
operable patient.
yes,
No, I
so
don't think so that any of our patient, from my understanding, so any local recurrence of SBRT has undergone a surgery at our institute. I
at
don't think so.
okay, okay. So there's a question by Dr. Geeta that if there is another lesion which comes up after treating a isolated met within 3 months, would you again offer SBRT to that? So it was probably a breast primary with a isolated lung met. We offered SBRT to this nodule, and after 3 months, a new nodule comes up. So again, we can offer SBRT
Yeah, we can offer SBRT depending on the location. If it is in the
location. Yes,
same location, obviously won't be helpful. But obviously, we need to take into account the biology of the disease,
biology. Yes,
because
that
it is recurred in the 3 months. So whenever you also, if the surgeons do the metastectomy and some other nodule comes up or pops up, so we know that the biology is not going to be very good. So we need to be very careful.
also we need to consider the organ at risk, because if
Yes.
it's going to be the same site or the same lobe, even the same lobe, the doses to the bronchial tree would be very high.
No, the same lobe I would not worry. So it's just the actual distance.
Okay,
So between
distance.
whatever
Okay,
you have treated first. So if the
okay,
actual distance is more than 2 or 3 centimeter, then we can do it. So
okay,
depending
okay.
upon where it has been treated,
Hmm.
I would be very hesitant to treat so SBRT treated at a different institute, and if that person comes to me and I do not have any radiology or I do not have any radiation therapy data, so I would be
And
very hesitant because of the beam arrangement.
yeah, yeah.
I would not be able to know.
Okay, okay, okay. Uh, Thank you, Anil. I think we have had a good discussion, and I'm very happy that we have captured your presentation on YouTube. So because you have presented a lot of evidence in a very short time, so a lot of people will go through that, and I am most interested in the evidence because it gives me a synopsis to read through before I face a radiation oncologist in a debate or sometime, and Dr. JP Agarwal is very vocal about it, and I'm always short of data in front of sir. So it will help me that now I have Anil's presentation to fall back into. But before we close this, Anil, because there are a lot of students that our aim is. So if you were to get if you were to check a copy of a student who has written a short note on this thing, what is that thing that it must have to ensure that it is a complete answer? I know you have completed the gamut of it, but what is the probably we would expect a 2 to 3 page or a 4 page answer for this, but what is essential it should have, what 3 4 studies that it should definitely mention, and what is that you would give that person a passing mark, a 5 out of 10?
Yeah. So if I can summarize my entire presentation on SBRT in 5 sentences. So first of all, as you have rightly said, is the definition. So SBRT is a method of external beam radiation therapy that accurately delivers a high dose of radiation in one or few fraction to an extracranial target. You can avoid extracranial target because SBRT anyway means extracranially only. So this is the first sentence that I would like to see in a short note or in any type of question. So then the indication is early stage non-small cell lung cancer, medically inoperable. If that student can write what do you mean by medically inoperable, it would be great. Otherwise, whoever the patient is not suitable for a lobectomy or a wedge resection can undergo an SBRT. SBRT provides an excellent local control rate with a low rate of toxicity is important. They should also comment about as compared to surgery, the overall survival rate is inferior to SBRT as per the current evidence, and we do not have any randomized control evidence to prove that SBRT is either equivalent or actually superior to the surgical arm. So these are the few things that I would like to have, and there are ongoing whatever. If you want to quote some evidence, so RTOG 0236 is the first phase 2 prospective studies that have shown that 5-year overall survival can come up to 40 to 45% at 5 years. So these are the most common sentences that we want to highlight whenever you want to talk about SBRT in early stage non-small cell lung cancer. And if you can say that if that student is so interested in radiation oncology, that any linear accelerator can do the job of SBRT. It doesn't require a very sophisticated like CyberKnife or something like tomotherapy or something. So any linear accelerator can do the job of SBRT with an adequate infrastructural facility, but the motion management is very important. If you do not manage your motion within your so whenever you are doing the SBRT treatment, you might end up in local recurrence. So motion management is very essential.
Thank you. Thank you. I think Anil has actually verbatimly given you the answer that has to be written, and it is actually told you what to write, and he was slow enough to actually write the answer. So thank you, Anil, for that clarity.
One more thing Dr. JP Agarwal has pointed out is the image guidance radiation therapy. As it is a very high dose of treatment and very accurate and precise, we need to have an image guided radiation therapy. That means we need to check whatever we are intended to deliver at a particular uh, at, a, at a particular point. It should be delivering at the same point only. So that's the image guided verification.
So immobilization also, I think, is an important aspect of
Yes.
that. And then, yes, I think.
Yeah.
So thank you, Anil. Dr. Geeta, your last thoughts on this?
Excellent talk. I mean, see, I'm not, for a surgeon, there are limitations to understanding radiation. But yes, SBRT we do understand because, it's like, just as we excise tumor with margins, they just make the tumor disappear with very precise radiation. So, radiation has come a long way. So whenever patients ask me कि ये ना इसके बहुत side effect होते हैं ना, I said that used to happen 20 years ago. It doesn't happen anymore.
Yeah.
So I think we have come a long way, and I think whatever technological advancements you see in radiation oncology has been tremendous. And re-radiation used to be such a taboo thing about say 10 years ago,
10 to 15 years ago.
And today you talk about re-radiation as if it is just one of those things. You just do it. So I think it's a great opportunity that way, and I think you live in a very good era that you're able to enjoy all these technological advancements,
Yes,
all to the good of the patient.
Yes.
Yeah.
So patients.
So
thank you so much, Dr. Anil. Excellent.
That's my pleasure. Thank you.
Thank you, Anil. And we also have the vote of approval from Dr. JP Prakash, JP sir, that it's a very nice, concise presentation. Thank you, Anil. Thank you, sir, for joining in, sir. It was really nice to have your thoughts on this, and having you around is always a blessing. And thank you so much for joining in, sir. Thank you so much. We'll join next week. We are still to find the correct speaker for next week. The topic is almost decided, but we are not have not found the right speaker, and probably the Diwali season is also affecting the enthusiasm around. So, but we'll surely have a class. The topic is something that we are excited about, but the speaker, we want to be very sure that we have the right speaker before we announce it, because having the right speaker makes the talk the more interesting and more relevant. That is why if we don't have the right speaker, we will change the topic altogether. So we'll let you know of the topic. And thank you so much. Thank you, Anil. Thank you, Dr. Geeta. Thank you, Dr. JP Agarwal, sir. And
thank you, Dr. JP Agarwal. You've raised the level of today's this thing. And we were actually thinking we'll have very few, but we had a pretty good attendance at the end of it. Yeah. Thank you.
Thank you. Good night. Good night.
Yes, good night,
Thank you.
everyone.
Good night.